Acute renal failure. A definition. Acute renal failure, ARF, is the sudden, potentially reversible interruption of kidney function, resulting in retention of nitrogenous waste products in body fluids. B. Classification and etiology. ARF is classified according to its cause. 1. Prerenal ARF stems from impaired renal perfusion, which may result from a. Reduced arterial blood volume, for example, dehydration, hemorrhage, vomiting, diarrhea, other gastrointestinal, GI, fluid loss. B. Urinary losses from excessive diuresis. C. Decreased cardiac output, for example, from congestive heart failure, CHF, or pericardial tamponade. D. Renal vascular obstruction, for example, stenosis. E. Severe hypotension. 2. Intrinsic ARF, intrarenal or parenchymal ARF, reflects structural kidney damage resulting from any of the following conditions. A. Acute tubular necrosis, ATN, the leading cause of ARF, may be associated with 1. Exposure to nephrotoxic aminoglycosides, anesthetics, pesticides, organic metals, and radiopaque contrast materials. 2. Ischemic injury, for example, surgery, circulatory collapse, severe hypotension. 3. Pigment, for example, hemolysis, myoglobinuria. B. Acute glomerulonephritis. C. Tubular obstruction, as from hemolytic reactions or uric acid crystals. D. Acute inflammation, for example, acute tubulointerstitial nephritis, papillary necrosis. E. Renal vasculitis. F. Malignant hypertension. G. Radiation nephritis. 3. Postrenal ARF results from obstruction of urine flow anywhere along the urinary tract including a. Ureteral obstruction, as from calculi, uric acid crystals, or thrombi. B. Bladder obstruction, as from calculi, thrombi, tumors, or infection. C. Urethral obstruction, as from strictures, tumors, or prostatic hypertrophy. D. Extrinsic obstruction, as from hematoma, inflammatory bowel disease, or accidental surgical ligation. C. Pathophysiology. ARF progresses in 3 phases. 1. Initiating phase. A. The initiating phase is defined as the time between the renal insult and the point at which extrarenal factors no longer reverse the damage caused by the obstruction or other cause of ARF. This phase may not be well defined clinically and may escape notice or diagnosis. B. Urine output may drop markedly to 400 ml/day or less, oliguria. In some patients, urine output falls below 100 ml/day, anuria. Oliguria may last only hours or as long as 4 to 6 weeks. However, it has been shown that 40% to 50% of ARF patients are not oliguric or anuric. C. Nitrogenous waste products accumulate in the blood. 1. Azotemia reflects urea accumulation due to impaired glomerular filtration and concentrating capacity. 2. Serum creatinine concentration, sulfate, phosphate, and organic acid levels climb rapidly. 48 Renal disorders. C. 3. Or accidental surgical ligation. C. Pathophysiology. ARF progresses in 3 phases. 1. Initiating phase. A. The initiating phase is defined as the time between the renal insult and the point at which extrarenal factors no longer reverse the damage caused by the obstruction or other cause of ARF. This phase may not be well defined clinically and may escape notice or diagnosis. B. Urine output may drop markedly to 400 ml/day or less, oliguria. In some patients, urine output falls below 100 ml/day, anuria. Oliguria may last only hours or as long as 4 to 6 weeks. However, it has been shown that 40% to 50% of ARF patients are not oliguric or anuric. C. Nitrogenous waste products accumulate in the blood. 1. Azotemia reflects urea accumulation due to impaired glomerular filtration and concentrating capacity. 2. Serum creatinine concentration, sulfate, phosphate, and organic acid levels climb rapidly. 48 Renal disorders. Heather A. Sweeney, Renal Disorders 979. D. The serum sodium concentration falls below normal from intracellular fluid shifting and dilution. E. Hyperkalemia occurs due to the accumulation of organic acids, metabolic acidosis. If potassium intake is not restricted or body potassium is not removed, hyperkalemia results. Without treatment, hyperkalemia may lead to neuromuscular depression and paralysis, impaired cardiac conduction, arrhythmias, respiratory muscle paralysis, cardiac arrest, and ultimately death. 2. Maintenance phase A. This phase begins when urine output rises above 500 ml/day, typically after several days of oliguria. A rise in urine output or a diuretic response may not be seen in non-oliguric patients. Increased urinary output does not signal recovery of renal function. B. Urine output rises in increments of several milliliters to 300 to 500 ml/day. Urine output may double from day to day in the initial recovery period. C. Azotemia and associated laboratory findings may persist until urine output reaches 1000 to 2000 ml/day. D. The maintenance phase carries a risk of fluid and electrolyte abnormalities, GI bleeding, infection, and respiratory failure. 3. Recovery phase. During the recovery phase, renal function gradually returns to normal. Most recovered renal function appears in the first 2 weeks, however, recovery of renal function may continue for a year. Residual impairment may persist indefinitely. D. Clinical evaluation 1. Physical findings. Initially, ARF causes azotemia and, in 50% to 60% of cases, oliguria. Later, electrolyte abnormalities and other severe systemic effects occur. A. Urine output typically is low, from 20 to 500 ml/day. Complete anuria is rare. B. Signs and symptoms of hyperkalemia, resulting from metabolic acidosis and reduced potassium excretion by impaired kidneys, include 1. Neuromuscular depression, for example, paresthesias, muscle weakness, paralysis. 2. Diarrhea and abdominal distension. 3. Slow or irregular pulse. 4. Electrocardiographic changes with potential cardiac arrest. C. Uremia, caused by excessive nitrogenous waste retention, leads to nausea, vomiting, diarrhea, edema, confusion, fatigue, neuromuscular irritability, and coma. D. Metabolic acidosis, a common complication of ARF, is evidenced by 1. Deterioration of mental status, obtundation, coma, and lethargy. 2. Depressed cardiac contractility and decreased vascular resistance, leading to hypotension, pulmonary edema, and ventricular fibrillation. 3. Nausea and vomiting. 4. Respiratory abnormalities, for example, hyperventilation, Kussmaul's respiration. E. Hyperphosphatemia arises from decreased phosphate excretion. It is generally not seen in ARF. 1. As serum phosphate rises, hypocalcemia results from the formation of insoluble calcium phosphate complexes. 2. The signs and symptoms relate to resultant hypocalcemia and metastatic soft tissue calcification. 3. Manifestations of hypocalcemia include A. Neuromuscular irritability, cramps, spasms, and tetany. B. Hypotension. C. Soft tissue calcification. D. Mental status changes, for example, confusion, mood changes, loss of intellect and memory. E. Hyperactive deep tendon reflexes, and Trousseau's and Chvostek's signs. F. Abdominal cramps. G. Stridor and dyspnea. F. Hyponatremia results from dilution and intravascular fluid shifts during the diuretic phase of ARF. Physical findings include lethargy, weakness, seizures, cognitive impairment, and possible reduction in level of consciousness. 980 Chapter 48I.
D. G. Intravascular volume depletion, suggesting pre-renal failure, may cause 1. Flat jugular venous pulses when the patient lies supine.
2. Orthostatic changes in blood pressure and pulse. 3. Poor skin turgor and dry mucous membranes. Other findings suggesting pre-renal failure include 1. An abdominal bruit, possibly indicating renal artery stenosis. 2. Increased paradoxis, suggesting pericardial tamponade. 3. Increased jugular venous pressure, pulmonary rales, and a third heart sound, signaling CHF. I. Postrenal failure caused by obstructed urinary flow may manifest itself in 1. A suprapubic or flank mass. 2. Bladder distension. 3. Costovertebral angle tenderness. 4. Prostate enlargement. 2. Diagnostic test results. A. Urinalysis includes an examination of sediment, identification of protein, glucose, ketones, and nitrites, and measurement of urinary pH and urine-specific gravity, concentration, or osmolality, dilution. Prior administration of fluids, diuretics, and changes in urinary pH may confound accurate diagnosis, using urinalysis. 1. Urinary sediment examination. A. Few casts and formed elements are found in pre-renal ARF. B. Pigmented cellular casts and renal tubular epithelial cells appear with ATN. C. Red blood cell and white blood cell casts generally reflect inflammatory disease. D. Large numbers of broad white cell casts suggest chronic renal failure. 2. The presence of blood in the urine, hematuria, or proteins, proteinuria, indicates renal dysfunction. 3. Urine-specific gravity ranges from 1.010 to 1.016 in ARF. 4. Urine osmolality typically rises in pre-renal ARF due to increased secretion of antidiuretic hormone. B. Measurement of urine sodium and creatinine levels can help classify ARF. 1. In pre-renal ARF, the urine creatinine concentration increases and urine sodium level decreases. 2. In intrinsic ARF resulting from ATN, the urine creatinine concentration decreases and the urine sodium level increases. C. Creatinine clearance, an index of the glomerular filtration rate, GFR, allows estimation of the number of functioning nephrons. Decreased creatinine clearance indicates renal dysfunction. A timed urine collection should be used to calculate GFR in acute renal failure. D. Blood chemistry provides an index of renal excretory function and body chemistry status. Findings typical of ARF include 1. Increased blood urea nitrogen, BUN. 2. Increased serum creatinine concentration. 3. Possible increase in hemoglobin and hematocrit values due to dehydration. 4. Abnormal serum electrolyte values. A. Serum potassium level above 5 MEq/L. B. Serum phosphate level above 2.6 MEq/L, 4.8 mg/dl. C. Serum calcium level below 4 MEq/L, 8.5 mg/dl, reflecting hypocalcemia. The serum calcium level must be correlated with the serum albumin level. Each rise or fall of 1 gram/dl of serum albumin beyond its normal range is responsible for a corresponding increase or decrease in serum calcium of approximately 0.8 mg/dl. A below normal serum albumin level may result in a deceptively low serum calcium level. D. Serum sodium level below 135 MEq/L, reflecting hyponatremia. 5. Abnormal arterial blood gas values, pH below 7.35, bicarbonate concentration, HCO3, below 22, reflecting metabolic acidosis E. Renal failure index, RFI, is the ratio of urine sodium concentration to the urine to serum creatinine ratio. The RFI helps determine the etiology of ARF. Typically, the RFI is less than 1 in pre-renal ARF or acute glomerulonephritis, a cause of intrinsic ARF. The RFI is greater than 2 in postrenal ARF and in other intrarenal causes of ARF. Renal disorders 981. F. Electrocardiography, ECG, may show evidence of hyperkalemia, that is, tall, peak T waves, widening QRS complexes, prolonged PR interval, progressing to decreased amplitude and disappearing P waves, and, ultimately, ventricular fibrillation and cardiac arrest. G. Radiographic findings. 1. Ultrasound may detect upper urinary tract obstruction. 2. Kidney, ureter, or bladder radiography may reveal A. Urinary tract calculi. B. Enlarged kidneys, suggesting ATN. C. Asymmetrical kidneys, suggesting unilateral renal artery disease, ureteral obstruction, or chronic pyelonephritis. 3. Radionuclide scan may reveal A. Bilateral differences in renal perfusion, suggesting serious renal disease. B. Bilateral differences in dye excretion, suggesting parenchymal disease or obstruction as the cause of ARF. C. Diffuse, slow, dense radionuclide uptake, suggesting ATN. D. Patchy or absent radionuclide uptake, possibly indicating severe, acute glomerulonephritis. 4. Computed tomography, CT, scan may provide better visualization of an obstruction. H. Renal biopsy may be performed in selected patients when other test results are inconclusive. E. Treatment objectives. 1. Correct reversible causes of ARF, preventing or minimizing further renal damage or complications. A. Discontinue nephrotoxic drugs, remove other nephrotoxins through dialysis or gastric lavage for poisonings. B. Treat underlying infection. C. Remove any urinary tract obstructions. 2. Correct and maintain proper fluid and electrolyte balance. Match fluid, electrolyte, and nitrogen intakes to urine output. 3. Treat body chemistry alterations, especially hyperkalemia and metabolic acidosis, when present. Treatment may include renal dialysis. 4. Improve urine output. 5. Treat systemic manifestations of ARF. F. Therapy. 1. Conservative management alone may suffice in uncomplicated ARF. A. Fluid management. 1. Fluid intake should match fluid losses. Sensible losses, i.e., urine, stool, tube drainage, and insensible losses, i.e., skin, respiratory tract, of 500 to 1000 milliliters/day should be included in fluid balance calculations. 2. Volume overload should be avoided to minimize the risk of hypertension and CHF. 3. The patient should be weighed daily to determine fluid volume status. B. Dietary measures. 1. Because catabolism accompanies renal failure, the patient should receive a high-calorie, low-protein diet. Such a diet helps to A. Reduce renal workload by decreasing production of end products of protein catabolism that the kidneys cannot excrete. B. Prevent ketoacidosis. C. Alleviate manifestations of uremia, for example, nausea, vomiting, confusion, fatigue. 2. If edema or hypertension is present, sodium intake should be restricted. 3. Potassium intake must be limited in most patients. Fruits, vegetables, and salt substitutes containing potassium should be limited or avoided. 2. Management of body chemistry alterations. A. Treatment of hyperkalemia. 1. Dialysis may be used to treat acute, life-threatening hyperkalemia, C2F.7. 2. Calcium chloride or calcium gluconate. A. Mechanism of action and therapeutic effects. Calcium chloride or calcium gluconate replaces and maintains body calcium, counteracting the cardiac effects of acute hyperkalemia. 982 Chapter 48I.
F. B.
Administration and dosage. When used to reverse hyperkalemia-induced cardiotoxicity, calcium chloride is given intravenously, as 5 to 10 milliliters of a 10% solution, 1.4 mEq Ca2 per milliliter, administered over 2 minutes. Doses of up to 20 milliliters of a 10% solution are safe when given slowly. Another 10 to 20 milliliters of a 10% solution placed in a larger fluid volume and administered slowly may follow the initial dose. Calcium gluconate is administered as 10 milliliters of a 10% solution, 1 gram, for 2 to 5 minutes. This may be repeated a second time. C. Precautions and monitoring effects. I. Intravenous. 4. Calcium is contraindicated in patients with ventricular fibrillation or renal calculi. 2. The infusion rate should not exceed half a milliliter per minute. Patients should remain recumbent for about 15 minutes after infusion. 3. The ECG should be monitored during calcium gluconate therapy. 4. Calcium gluconate should not be mixed with solutions containing sodium bicarbonate because this can lead to precipitation. V. Adverse effects include hypotension, tingling sensations, and renal calculus formation. D. Significant interactions. Calcium may cause increased digitalis toxicity when administered concurrently with digitalis preparations. 3. Sodium bicarbonate may be given as an emergency measure for severe hyperkalemia or metabolic acidosis. A. Mechanism of action and therapeutic effect. 4. Sodium bicarbonate restores bicarbonate that the renal tubules cannot reabsorb from the glomerular filtrate and increases arterial pH. This results in a shift of potassium into cells and reduces serum potassium concentration. B. Onset of action is 15 to 30 minutes. C. Administration and dosage. I. Sodium bicarbonate is administered intravenously. 2. The dosage is calculated as follows. 50% of body weight, kg. Desired arterial bicarbonate, HCO3. Actual HCO3, 1 ampule, 50 mEq, may be given intravenously for 5 minutes. D. Precautions and monitoring effects. I. To avoid sodium and fluid overload, sodium bicarbonate must be given cautiously. Half of the patient's bicarbonate deficit is replaced over the first 12 hours of therapy. 2. Sodium bicarbonate may precipitate calcium salts in 4 solutions and should not be mixed in the same infusion fluid. 3. Arterial blood gas values and serum electrolyte levels should be monitored closely during sodium bicarbonate therapy. 4. Regular insulin with dextrose. A. Mechanism of action and therapeutic effect. The insulin causes an intracellular shift of potassium. The combination of insulin with dextrose deposits potassium with glycogen in the liver, reducing the serum potassium. B. Onset of action is 15 to 30 minutes. C. Administration and dosage. Regular insulin, 10 units in 500 milliliters of 10% dextrose, is administered intravenously for 60 minutes. D. Precautions and monitoring effects. I. The serum glucose level should be monitored during therapy. 2. The patient should be assessed for signs and symptoms of fluid overload. 5. Sodium polystyrene sulfonate, SPS, Kxalate, A. Mechanism of action. SPS is a potassium-removing resin that exchanges sodium ions for potassium ions in the intestine. 1 gram of SPS exchanges 0.5 to 1 mEq/L of potassium. The SPS is distributed throughout the intestines and excreted in the feces. B. Therapeutic effect. Administered as an adjunctive treatment for hyperkalemia, SPS reduces potassium levels in the serum and other body fluids. Renal disorders 983. C. Onset of action of orally administered SPS is 2 hours. Effects are seen in 1 hour when SPS is administered as a retention enema. D. Administration and dosage. I. SPS is usually administered orally, although it may be given through a nasogastric tube. The oral dose is 15 to 30 grams in a suspension of 70% sorbitol, administered every 4 to 6 hours until the desired therapeutic effect is achieved. 2. When oral or nasogastric administration is not possible due to nausea, vomiting, or paralytic ileus, SPS may be given by retention enema. The rectal dose is 30 to 50 grams in 100 milliliters of sorbitol as a warm emulsion, administered deep into the sigmoid colon every 6 hours. Administration may be done with a rubber tube that is taped in place or via a Foley catheter with a balloon inflated distal to the anal sphincter. Precautions and monitoring effects. The patient's serum electrolyte levels should be monitored closely during SPS therapy. Sodium, chloride, bicarbonate, and pH should be monitored in addition to potassium. 2. SPS therapy usually continues until the serum potassium level drops to between 4 and 5 mEq/L. 3. The patient should be assessed regularly for signs of potassium depletion, including irritability, confusion, cardiac arrhythmias, ECG changes, and muscle weakness. 4. SPS exchanges sodium for potassium, so sodium overload may occur during therapy. Patients with hypertension or CHF should be closely monitored. For oral administration, SPS should be mixed only with water or sorbitol. Orange juice, which has a high potassium content, should not be used because it decreases the effectiveness of the SPS. For rectal administration, SPS should be mixed only with water and sorbitol, never with mineral oil. Adverse effects of SPS include constipation, fecal impaction with rectal administration, nausea, vomiting, and diarrhea. 7. SPS should not be used as the sole agent in the treatment of severe hyperkalemia. Other agents or therapies should be used in conjunction with this agent. Significant interactions. Magnesium hydroxide and other non-absorbable cation-donating laxatives and antacids may decrease the effectiveness of potassium exchange by SPS and may cause systemic alkalosis. Treatment of metabolic acidosis. Sodium bicarbonate may be given if the arterial pH is below 7.35. Treatment of hyperphosphatemia. 1,4-calcium is first-line therapy for severe life-threatening hyperphosphatemia. Calcium reduces the serum phosphorus concentration by chelation. 2. Oral calcium salts bind dietary phosphorus in the GI tract. 3. Sevelamer, Renagel, is a non-ionic polymer that binds dietary phosphorus in the GI tract. 4. Dialysis may be used to treat acute, life-threatening hyperphosphatemia accompanied by acute hypocalcemia. It is also performed when volume overload is present. 5. Aluminum hydroxide, Alternagel, an aluminum-containing antacid. Mechanism of action and therapeutic effect. Aluminum binds excess phosphate in the intestine, thereby reducing phosphate concentration. Onset of action is 6 to 12 hours. Administration and dosage. Aluminum hydroxide is administered orally as a tablet or suspension. For the treatment of hyperphosphatemia, 0.5 to 2.0 or 15 to 30 milliliters of suspension is administered 3 or 4 times daily with meals. Precautions and monitoring effects. Aluminum hydroxide may cause constipation and anorexia. 2. Serum phosphate levels should be monitored because aluminum hydroxide can cause phosphate depletion. 3. Aluminum hydroxide can cause calcium resorption and bone demineralization. 984 Chapter 48I.
Treatment of hypocalcemia.
Immediate treatment is necessary if the patient has severe hypocalcemia, as evidenced by tetany. 1. Calcium gluconate, mechanism of action and therapeutic effect. This drug replaces and maintains body calcium, raising the serum calcium level immediately. Administration and dosage. When used to reverse hypocalcemia, calcium gluconate is administered intravenously in a dosage of 1 to 2 grams for a period of 10 minutes, followed by a slow infusion, for 6 to 8 hours, of an additional 1 gram. Precautions, monitoring effects, and significant interactions. Frequent determinations of serum, or ionized in the critically ill patient, calcium concentrations should be performed. 2. Serum calcium concentrations usually should not be allowed to exceed 12 mg/dl. 3. Avoid administration of 4-calcium in patients taking digoxin, as inotropic and toxic effects are synergistic and arrhythmias can occur. 2. Oral calcium salts. Calcium carbonate, chloride, gluconate, or lactate may be given by mouth when oral intake is permitted or if the patient has relatively mild hypocalcemia. The usual adult dosage is 4 to 6 grams/day given in 3 or 4 divided doses. Treatment of hyponatremia. 1. Moderate or asymptomatic hyponatremia may require only fluid restriction. 2. Sodium chloride may be given for severe symptomatic hyponatremia, i.e., a serum sodium level below 120 mEq/L. Mechanism of action and therapeutic effect. Sodium chloride replaces and maintains sodium and chloride concentration, thereby increasing extracellular tonicity. B. Administration and dosage. A 3% or 5% sodium chloride solution may be administered by slow 4 infusion. The amount of solution needed is calculated from the following equation. Normal serum sodium level, actual serum sodium level. Total body water. 2. Typically, 400 milliliters or less is administered. C. Precautions and monitoring effects. Hypertonic sodium chloride must be administered very slowly to avoid circulatory overload, pulmonary edema, or central pontine demyelination. 2. Serum electrolyte levels must be monitored frequently during therapy. 3. Excessive infusion may cause hypernatremia and other serious electrolyte abnormalities and may worsen existing acidosis. Infusion rate should not exceed 0.5 mEq/kg per hour. 3. Management of systemic manifestations. Treatment of fluid overload and edema. As water and sodium accumulate in extracellular fluid during ARF, fluid overload and edema may occur. Diuretics and dopamine may be given to reduce fluid volume excess and edema. Treatment should be initiated as soon as possible after oliguria begins. Mannitol or a loop diuretic may be used. Thiazide diuretics are avoided in renal failure because they are ineffective when creatinine clearance is less than 25 milliliters per minute, and they may worsen the patient's clinical status. 1. Step 1. Loop, high ceiling, diuretics. These agents include furosemide, Lasix, bumetanide, Bumex, torsemide, Demodex, and ethacrynic acid, Ethacryn. Loop diuretics are more potent and faster acting than thiazide diuretics. Mechanism of action and therapeutic effects. Loop diuretics inhibit sodium and chloride reabsorption at the loop of Renal, promoting water excretion. B. Onset of action for an oral dose is 1 hour, several minutes for an 4 dose. Duration of action for an oral dose is 6 to 8 hours, 2 to 3 hours for an 4 dose. C. Administration and dosage. Furosemide, the most commonly used loop diuretic, usually is administered intravenously in patients with ARF to hasten the therapeutic effect. The dose is titrated to the patient's needs. The usual initial dose is 1.0 to 1.5 mg/kg. If the first dose does not produce a urine output of 10 to 15 milliliters within 22. Renal disorders 985. 30 minutes, a dose of 2 to 3 mg/kg is administered. If the desired response still does not occur, a dose of 3 to 6 mg/kg is administered 20 to 30 minutes after the second dose. 2. Bumetanide may be given to patients who are unresponsive or allergic to furosemide. The usual dosage, administered intravenously or intramuscularly in the treatment of ARF, is 0.5 to 1.0 mg/day. However, some patients may require up to 20 mg/day. A second or third dose may be given at intervals of 2 to 3 hours. When bumetanide is given orally, the dosage is 0.5 to 2.0 mg/day, repeated up to 2 times, if necessary, at intervals of 2 to 3 hours. 3. Ethacrynic acid is less commonly used to treat ARF because ototoxicity, sometimes irreversible, is associated with its use. It may be given intravenously, slowly for several minutes, in a dose of 50 to 100 milligrams. The usual oral dosage is 50 to 200 milligrams/day. Some patients may require up to 200 mg twice daily. Ethacrynic acid can be safely given to patients who may have a sulfonamide allergy, which would preclude them from therapy with furosemide or torsemide. 4. Torsemide may also be given to patients unresponsive to or allergic to furosemide. The usual dose is 20 mg, administered intravenously. Doses may be increased by doubling up to 200 mg. 10 to 20 mg of torsemide is equipotent to 40 mg of furosemide or 1 mg bumetanide. Torsemide offers better bioavailability compared to other loop diuretics, however, it is considerably more expensive. D. Precautions and monitoring effects. I. Loop diuretics must be used cautiously because they may cause overdiuresis leading to orthostatic hypotension and fluid and electrolyte abnormalities, including volume depletion and dehydration, hypocalcemia, hypokalemia, hypochloremia, hyponatremia, hypomagnesemia, and transient ototoxicity, especially with rapid 4 injection. 2. Serum electrolyte levels should be monitored frequently and the patient assessed regularly for signs and symptoms of electrolyte abnormalities. 3. Blood pressure and pulse rate should be assessed during diuretic therapy. 4. GI reactions include abdominal pain and discomfort, diarrhea, with furosemide and ethacrynic acid, and nausea, with bumetanide. V. Blood glucose levels should be monitored in diabetic patients receiving loop diuretics because these agents may cause hyperglycemia and impaired glucose tolerance. Vi. Patients who are allergic to sulfonamides may be hypersensitive to bumetanide and furosemide. 7. Furosemide and ethacrynic acid may cause agranulocytosis. E. Significant interactions. I. Aminoglycoside antibiotics may potentiate ototoxicity when administered with any loop diuretic. 2. Nonsteroidal anti-inflammatory drugs, NSAIDs, may hamper the diuretic response to furosemide and bumetanide. Probenecid may hamper the diuretic response to bumetanide. 3. Ethacrynic acid may potentiate the anticoagulant effects of warfarin, Coumadin. 2. Step 2. Mannitol, an osmotic diuretic, is a non-reabsorbable polysaccharide. A. Mechanism of action and therapeutic effect. Mannitol increases the osmotic pressure of the glomerular filtrate. Fluid from interstitial spaces is drawn into blood vessels, expanding plasma volume and maintaining or increasing the urine flow. This drug may be given to prevent ARF in high-risk patients, such as those undergoing surgery or suffering from severe trauma or hemolytic transfusion reactions. B. Onset of action is 15 to 30 minutes. Duration of action is 3 to 4 hours. C. Administration and dosage. Mannitol is available in solutions ranging from 5% to 25%. For the treatment of oliguric ARF or the prevention of ARF, the usual initial dose is 12.5 to 25.0 grams, administered intravenously. The maximum daily dosage is 100 grams, administered intravenously. The exact concentration of the solution is determined by the patient's fluid requirements. 986 Chapter 48I. F. D. Precautions and monitoring effects. I. Mannitol is contraindicated in patients with anuria, pulmonary edema or congestion, severe dehydration, and intracranial hemorrhage, except during craniotomy. 2. Mannitol may cause or worsen pulmonary edema and circulatory overload. If signs and symptoms of these problems develop, the infusion should be stopped. 3. Other adverse effects of mannitol include fluid and electrolyte abnormalities, water intoxication, headache, confusion, blurred vision, thirst, nausea, and vomiting. 4. Vital signs, urine output, daily weight, cardiopulmonary status, and serum and urine sodium and potassium levels should be monitored during mannitol therapy. V. Mannitol solutions with undissolved crystals should not be administered. 4. Dialysis. If the previously mentioned strategies fail, hemodialysis or peritoneal dialysis may be necessary in ARF patients who develop anuria, acute fluid overload, severe hyperkalemia, metabolic acidosis, or a Bunn level above 100 mg/dl. 2. Chronic kidney disease. A definition. Chronic kidney disease, CKD, is the progressive, irreversible deterioration of renal function, usually resulting from long-standing disease. CKD sometimes derives from ARF that does not respond to treatment. B. Classification and pathophysiology. 1. CKD is defined as kidney damage or GFR 60 ml per minute/1.73 square meters for 3 months. Kidney damage is defined as pathological abnormalities or markers of damage, including abnormalities in blood or urine tests or imaging studies. CKD has recently been reclassified as stages I to V to denote the severity of renal impairment. Generally, CKD, if left untreated, progresses at a predictable, steady rate from stage I through stage V. A. Stage I is defined as kidney damage with a normal or increased GFR. The corresponding GFR in stage I CKD is usually 90 ml per minute/1.73 square meters. B. Stage 2 is defined as kidney damage or a mildly decreased GFR, 60 to 89 ml per minute/1.73 square meters. C. Stage 3 signifies moderate reductions in GFR, 30 to 59 ml per minute/1.73 square meters. D. Stage 4 connotes a GFR of 15 to 29 ml per minute/1.73 square meters. E. Stage V is kidney failure or a GFR of 15 ml per minute/1.73 square meters. 2. As CKD progresses, nephron destruction worsens, leading to deterioration in the kidney's filtration, reabsorption, and endocrine functions. 3. Renal function typically does not diminish until about 75% of kidney tissue is damaged. Ultimately, the kidneys become shrunken, fibrotic masses. See etiology. Causes of CKD in adults. 1. Diabetic nephropathy. 2. Hypertension. 3. Glomerulonephritis. 4. Polycystic kidney disease. 5. Long-standing vascular disease, for example, renal artery stenosis. 6. Long-standing obstructive uropathy, for example, renal calculi. 7. Exposure to nephrotoxic agents. D. Clinical evaluation. 1. Physical findings. Signs and symptoms, which vary widely, do not appear until renal insufficiency progresses to renal failure. A. Metabolic abnormalities include loss of the ability to maintain sodium, potassium, and water homeostasis, leading to hyponatremia or hypernatremia, based on relative sodium or water intake. Hyperkalemia is uncommon until end-stage disease. Fluid overload, edema, and CHF may become a problem unless fluid intake is closely managed.
As renal failure progresses, the inability to excrete acid and maintain buffer capacity leads to metabolic acidosis, CI.D.1.B, D, G, H. Calcium and phosphate metabolism is altered due to hyperparathyroidism. B. Neurological manifestations include short attention span, loss of memory, and listlessness. As CKD progresses, these advance to confusion, stupor, seizures, and coma. Neuromuscular findings include peripheral neuropathy and pain, itching, and a burning sensation. Renal disorders. 987. Particularly in the feet and legs, patients may appear intoxicated. If dialysis is not started after these abnormalities occur, motor involvement begins, including loss of deep tendon reflexes, weakness, and finally, quadriplegia. C. Cardiovascular problems include arterial hypertension, peripheral edema, CHF, and pulmonary edema. Uremic pericarditis is now increasingly infrequent as a result of early dialysis. D. GI manifestations include hiccups, anorexia, nausea, vomiting, constipation, stomatitis, and an unpleasant taste in the mouth. CKD patients have an increased incidence of ulcers, pancreatitis, and diverticulosis. E. Respiratory problems include dyspnea when CHF is present, pulmonary edema, pleuritic pain, and uremic pleuritis. F. Integumentary findings typically include pale yellowish, dry, scaly skin,
severe itching, uremic frost, ecchymosis, purpura, and brittle nails and hair. G. Musculoskeletal changes range from muscle and bone pain to pathological fractures and calcifications in the brain, heart, eyes, joints, and vessels. Soft tissue calcification and renal osteodystrophy may occur. H. Hematological disturbances include anemia. The signs and symptoms of anemia arise from lack of epidin alpha and reduced lifespan of red blood cells, including 1. Pallor of the skin, nail beds, palms, conjunctiva, and mucosa. 2. Abnormal bruising or ecchymosis, and uremic bleeding due to platelet inactivation. 3. Dyspnea and angina pectoris. 4. Extreme fatigue. 2. Diagnostic test results. A. Creatinine clearance may range from 0 to 90 milliliters per minute, reflecting renal impairment. B. Blood tests typically show 1. Elevated BUN and serum creatinine concentration. 2. Reduced arterial pH and bicarbonate concentration. 3. Reduced serum calcium level. 4. Increased serum potassium and phosphate levels. 5. Possible reduction in the serum sodium level. 6. Normochromic, normocytic anemia, hematocrit 20% to 30%. C. Urinalysis may reveal glycosuria, proteinuria, erythrocytes, leukocytes, and casts. Specific gravity is fixed at 1.010. D. Radiographic findings. Kidney, ureter, and bladder radiography, 4-pyelography, renal scan, renal arteriography, and nephrotomography may be performed. Typically, these tests reveal small kidneys, less than 8 centimeters in length. Treatment objectives. 1. Improve patient comfort and prolong life. 2. Treat systemic manifestations of CKD. 3. Correct body chemistry abnormalities. F. Therapy. Management of the CKD patient is generally conservative. Dietary measures and fluid restriction relieve some symptoms of CKD and may increase patient comfort and prolong life until dialysis or renal transplantation is required or available. 1. Treatment of edema. Angiotensin-converting enzyme, ACE, inhibitors and diuretics may be given to manage edema and CHF and to increase urine output. A. ACE inhibitors, captopril, Capitan, enalapril, Vasotec, lisinopril, Prinavil, Zestril, Fascinapril, Monopril, are widely used to delay progression of CKD because they help preserve renal function and typically cause fewer adverse effects than other antihypertensive agents. They also decrease proteinuria and nephrotic syndrome. B. Diuretics. An osmotic diuretic, a loop diuretic, or a thiazide-like diuretic may be given. 1. Osmotic and loop diuretics. CI.F.3.A. 1. 2. For information on the use of these drugs in renal failure. 2. Thiazide-like diuretics. Metolazone, Zeroxylin, is the most commonly used thiazide diuretic in CKD. A. Mechanism of action and therapeutic effect. Metolazone reduces the body's fluid and sodium volume by decreasing sodium reabsorption in the distal convoluted tubule, thereby increasing urinary excretion of fluid and sodium. 988 Chapter 48 2.
F. B. Administration and dosage.
Metolazone is given orally at 5 to 20 mg/day. The dose is titrated to the patient's needs. Due to its long half-life, metolazone may be given every other day. Furosemide and metolazone act synergistically. Combination use is common, and metolazone should be administered 30 minutes before furosemide to achieve the optimal diuretic effect. C. Precautions and monitoring effects. I. Metolazone should not be given to patients with hypersensitivity to sulfonamide derivatives, including thiazide. 2. To avoid nocturia, the daily dose should be given in the morning. 3. Metolazone may cause hematological reactions, such as agranulocytosis, aplastic anemia, and thrombocytopenia. 4. Fluid volume depletion, hypokalemia, hyperuricemia, hyperglycemia, and impaired glucose tolerance may occur during metolazone therapy. V. Metolazone may cause hypersensitivity reactions, including vasculitis and pneumonitis. D. Significant interactions. I. Diazoxide may potentiate the antihypertensive, hyperglycemic, and hyperuricemic effects of metolazone. 2. Cholestyramine and cholestyramine decrease the absorption of metolazone. 2. Treatment of hypertension. Antihypertensive agents may be needed if blood pressure becomes dangerously high as a result of edema and the high renin levels that occur in CKD. Antihypertensive therapy should be initiated in the lowest effective dose and titrated according to the patient's needs. A. ACE inhibitors, captopril, enalapril, lisinopril, fasinopril, as mentioned in 2F.1.a. B. Dihydropyridine calcium channel blockers, including amlodipine, Norvasc, and felodipine, Plendil, have similar effects and may be used instead of ACE inhibitors. C. Adrenergic blockers, including propranolol, Indarol, and atenolol, tenormin, reduce blood pressure through various mechanisms. D. Other antihypertensive agents are sometimes used in the treatment of CKD, including adrenergic drugs, clonidine, catapres, and vasodilators, such as hydralazine, apresilene. 3. Treatment of hyperphosphatemia involves administration of a phosphate binder, such as aluminum hydroxide or calcium carbonate, Ci.F.2.c. 4. Treatment of hypocalcemia A. Oral calcium salts, Ci.F.2.d. 2. B. Vitamin D. 1. Mechanism of action and therapeutic effect. Vitamin D promotes intestinal calcium and phosphate absorption and utilization and, thus, increases the serum calcium concentration. 2. Choice of agent. For the treatment of hypocalcemia in CKD and other renal disorders, calcitriol, Recaltrol, vitamin D3, the active form of vitamin D, is the preferred vitamin D supplement because of its greater efficacy and relatively short duration of action. Other single-entity preparations include dihydrotacosterol, ergocalciferol, calciferol, doxorcalciferol, hectorol, and paracalcidol, Zempler. 3. Administration and dosage. Calcitriol is given orally or via 4. The dose is titrated to the patient's needs. 0.5 to 1.0 mg/day may be effective. 4. Precautions and monitoring effects. A. Vitamin D administration may be dangerous in patients with renal failure and must be used with extreme caution. B. Vitamin D toxicity may cause a wide range of signs and symptoms, including headache, dizziness, ataxia, convulsions, psychosis, soft tissue calcification, conjunctivitis, photophobia, tinnitus, nausea, diarrhea, pruritus, and muscle and bone pain. C. Vitamin D has a narrow therapeutic index, necessitating frequent measurement of BUN and serum urine calcium and potassium levels. Renal disorders 989. 5. Treatment of other systemic manifestations of CKD-A. Treatment of anemia includes administration of iron, for example, ferrous sulfate, folate supplements, and epitin alpha. 1. Severe anemia may warrant transfusion with packed red blood cells. 2. Epitin alpha, Procrit, Epigen, stimulates the production of red cell progenitors and the production of hemoglobin. It also accelerates the release of reticulocytes from the bone marrow. A. An initial dose of epitin alpha is 50 to 100 U/kg intravenously or subcutaneously 3 times a week. The dose may be adjusted upward to elicit the desired response. B. Epitin alpha works best in patients with a hematocrit below 30%. During the initial treatment, the hematocrit increases 1.0% to 3.5% in a 2-week period. The target hematocrit is 33% to 35%. Maintenance doses are titrated based on hematocrit after this level is reached. C. Epitin alpha therapy should be temporarily stopped if hematocrit exceeds 36%. Additional side effects include hypertension in up to 25% of patients. Headache and malaise have been reported. D. The effects of epitin alpha are dependent on a ready supply of iron for hemoglobin synthesis. Patients who do not respond should have iron stores checked. This includes serum iron, total iron binding capacity, transferrin saturation, and serum ferritin. Iron supplementation should be increased as indicated. 3. Darbepoetin, Aranesp, is an epidin alpha analog. Its advantage is a prolonged plasma half-life, thus allowing it to be administered once weekly or biweekly. 4. Intravenous iron products may be given to replete iron stores. This route is preferred to oral supplementation due to low oral bioavailability and GI intolerance. Iron dextran is commonly used, however, it is associated with hypotension and anaphylaxis. Newer iron products include sodium ferric gluconate and iron sucrose, which are better tolerated and can be infused more rapidly compared to iron dextran. Patients with severe iron deficiency may receive up to a total of 1 gram of an iron preparation over several days. The rate of infusion depends on the preparation used. B. Treatment of GI disturbances. 1. Antiemetics help control nausea and vomiting. 2. Docusate sodium or methylcellulose may be used to prevent constipation. 3. Enemas may be given to remove blood from the GI tract. C. Treatment of skin problems. An antipruritic agent, such as diphenhydramine, Benadryl, may be used to alleviate itching. 6. Management of body chemistry abnormalities, CI.F.2. 7. Dialysis. When CKD progresses to end-stage renal disease and no longer responds to conservative measures, long-term dialysis or renal transplantation is necessary to prolong life. A. Hemodialysis is the preferred dialysis method for patients with a reduced peritoneal membrane, hypercatabolism, or acute hyperkalemia. 1. This technique involves shunting of the patient's blood through a dialysis membrane-containing unit for diffusion, osmosis, and ultrafiltration. The blood is then returned to the patient's circulation. 2. Vascular access may be obtained via an arteriovenous fistula or an external shunt. 3. The procedure takes only 3 to 8 hours. Most patients need 3 treatments a week. With proper training, patients can perform hemodialysis at home. 4. The patient receives heparin during hemodialysis to prevent clotting. 5. Various complications may arise, including clotting of the hemofilter, hemorrhage, hepatitis, anemia, septicemia, cardiovascular problems, air embolism, rapid shifts in fluid and electrolyte balance, itching, nausea, vomiting, headache, seizures, and aluminum osteodystrophy. B. Peritoneal dialysis is the preferred dialysis method for patients with bleeding disorders and cardiovascular disease. 1. The peritoneum is used as a semipermeable membrane. A plastic catheter inserted into the peritoneum provides access for the dialysate, which draws fluids, wastes, and electrolytes across the peritoneal membrane by osmosis and diffusion. 990 Chapter 48 2. F. 2. Peritoneal dialysis can be carried out in 3 different modes. A. Intermittent peritoneal dialysis is an automatic cycling mode lasting 8 to 10 hours, performed 3 times a week. This mode allows nighttime treatment and is appropriate for working patients. B. Continuous ambulatory peritoneal dialysis is performed daily for 24 hours with 4 exchanges daily. The patient can remain active during the treatment. C. Continuous cyclic peritoneal dialysis may be used if the other 2 modes fail to improve creatinine clearance. Dialysis takes place at night. The last exchange is retained in the peritoneal cavity during the day, then drained that evening. 3. Advantages of peritoneal dialysis include a lack of serious complications, retention of normal fluid and electrolyte balance, simplicity, reduced cost, patient independence, and a reduced need, or no need, for heparin administration. 4. Complications of peritoneal dialysis include hyperglycemia, constipation, and inflammation or infection at the catheter site. Also, this method carries a high risk of peritonitis. 8. Renal transplantation. This surgical procedure allows some patients with end-stage renal disease to live normal and, in many cases, longer lives. A. Histocompatibility must be tested to minimize the risk of transplant rejection and failure. Human leukocyte antigen, HLA, type, mixed lymphocyte reactivity, and blood group types are determined to assess histocompatibility. B. Renal transplant material may be obtained from a living donor or a cadaver. C. 3 types of graft rejection can occur. 1. Hyperacute, immediate, rejection results in graft loss within minutes to hours after transplantation. A. Acute urine flow cessation and bluish or mottled kidney discoloration are intraoperative signs of hyperacute rejection. B. Postoperative manifestations include kidney enlargement, fever, anuria, local pain, sodium retention, and hypertension. C. Treatment for hyperacute rejection is immediate nephrectomy. 2. Acute rejection may occur 4 to 60 days after transplantation. 3. Chronic rejection occurs more than 60 days after transplantation. A. Signs and symptoms include low-grade fever, increased proteinuria, azotemia, hypertension, oliguria, weight gain, and edema. B. Treatment may include alkylating agents, cyclosporin, anti-lymphocyte globulin, and corticosteroids. In some cases, nephrectomy is necessary. D. Complications include 1. Infection, diabetes, hepatitis, and leukopenia, resulting from immunosuppressive therapy. 2. Hypertension, resulting from various causes. 3. Cancer, for example, lymphoma, cutaneous malignancies, head and neck cancer, leukemia, colon cancer. 4. Pancreatitis and mental and emotional disorders, for example, suicidal tendencies, severe depression, brought on by steroid therapy. 1. Severe hypotension may result in what type of acute renal failure? A. Pre-renal, B. Intrarenal, C. Postrenal, D. Intrinsic, E. Parenchymal. 2. Why might sodium polystyrene sulfonate, SPS, be utilized in ARF? A. It reduces calcium levels in the serum. B. It increases calcium levels in the serum. C. It increases potassium levels. D. It reduces potassium levels in the serum. E. It elevates glucose levels. Study questions. Renal disorders 991. 3. Why are thiazide diuretics avoided in patients with renal failure? A. Overdiuresis may occur. B. Patients are often allergic to furosemide. C. They are ineffective when creatinine clearance is less than 25 milliliters per minute. D. They are too costly. E. Sodium and potassium are already depleted. 4. The following are causes of chronic kidney disease except A. Diabetic nephropathy. B. Hypertension. C. Glomerulonephritis. D. Long-term exposure to acetaminophen. E. Polycystic kidney disease. 5. What is the major difference between epidin alpha and darbepoetin? A. Epidin alpha has a longer plasma half-life. B. Darbepoetin has a longer plasma half-life. C. Epidin alpha does not require adequate iron stores. D. Darbepoetin does not require adequate iron stores. E. Epidin alpha is a newer agent. Answers and explanations. 1. The answer is A. Ci.B.1.E. Prerenal ARF stems from impaired renal perfusion, which may result from reduced arterial volume, urinary losses from excessive diuresis, decreased cardiac output, renal vascular obstruction, and severe hypotension. 2. The answer is D. Ci.F.2.A. 5. B. SPS is a potassium-removing resin that exchanges sodium ions for potassium ions in the intestine. 1 gram of SPS exchanges 0.5 to 1.0 meq/L of potassium. The SPS is distributed throughout the intestines and excreted in the feces. It is administered as an adjunctive treatment for hyperkalemia since SPS reduces potassium levels in the serum and other body fluids. 3. The answer is C. Ci.F.3.A. Thiazide diuretics are avoided in renal failure because they are ineffective when creatinine clearance is less than 25 milliliters per minute and they may worsen the patient's clinical status. 4. The answer is D, C2C. Long-term exposure to acetaminophen, APAP, has not been shown to be a cause of chronic kidney disease. APAP can lead to chronic hepatic disorders such as chronic liver failure. The other listed conditions have been shown to lead to chronic kidney disease. 5. The answer is B, C2F.5.A. 3. Darbepoetin is an epidin analog that has a prolonged plasma half-life that allows for once-weekly or biweekly dosing compared to a 3 times a week regimen with epidin alpha. 49 Hepatic disorders. Heather A. Sweeney, 992. I. Acute liver failure, ALF, A. General information 1. ALF is a rare condition. The United States approximates 2,000 cases a year. 2. It is classified by a rapid deterioration, less than 26 weeks, of liver function, which results in jaundice, coagulopathy, international normalized ratio, INR, greater than 1.5, and hepatic encephalopathy in previously normal individuals. 3. The most common causes of ALF are drug-induced liver injury, viral hepatitis, autoimmune liver disease, and hypoperfusion. B. Signs and symptoms 1. Right upper quadrant tenderness 2. Nausea, vomiting 3. Jaundice. C. Diagnosis. 1. All patients with clinical or laboratory evidence of moderate to severe acute hepatitis should have a measurement of prothrombin time. 2. If the prothrombin time is prolonged by 4 to 6 seconds or more, 1 Indian rupee and 50 paise, and there is evidence of altered sensorium, the diagnosis of ALF is established and hospital admission is mandatory. 3. Since ALF may progress rapidly, early transfer to the ICU is recommended once the diagnosis of ALF is made. 4. Seek specific cause of ALF. D. Treatment. 1. Admit patient to ICU. 2. Specific treatment is dependent on etiology of ALF. 3. Consider need for liver transplantation. 2. Acetaminophen hepatotoxicity. A. General information 1. In the United States, acetaminophen, APAP, is the leading cause of acute liver failure. 2. APAP is a dose-related toxin. To cause toxicity, an acute overdose usually totals 150 mg/kg, about 7.5 grams in adults, within 24 hours. 3. The main toxic metabolite of APAP is N-acetyl P-benzoquinone imine, NIPK, which is produced by the hepatic P450 system. Glutathione in the liver normally detoxifies NIPK. An acute overdose of APAP depletes glutathione stores, which results in an accumulation of NIPK that causes hepatocellular necrosis. 4. Likelihood and severity of hepatotoxicity from an acute APAP ingestion is predicted by the serum APAP level. B. Signs, symptoms, and labs, post-ingestion times. 1. Stage I, 0 to 24 hours, anorexia, nausea, vomiting. 2. Stage II, 24 to 72 hours, right upper quadrant pain, elevated aspartate aminotransferase, AST, and alanine aminotransferase, ALT, possible elevation of bilirubin and prothrombin time, PT. 3. Stage III, 72 to 96 hours, vomiting, peaking of AST, ALT, bilirubin, and 4 Indian rupees. Stage 4, greater than 5 days, resolution of hepatotoxicity or progression to multiple organ failure. Hepatic disorders 993. C. Treatment. 1. Administer activated charcoal A. Ideally give within 1 hour of ingestion. It may be of benefit as long as 3 to 4 hours after ingestion. B. Adult oral dose, 25 to 100 grams as a single dose. If multiple doses are needed, additional doses may be given as 12.5 grams per hour. 2. Administer N-acetylcysteine, acetadote, A. N-acetylcysteine is a precursor for glutathione and decreases APAP toxicity by increasing glutathione hepatic stores. It does not reverse damage to liver cells that have already been injured. B. Ideally begin treatment within 8 hours of ingestion. It may be off value 48 hours or more after ingestion. C. Adult oral dose, 140 mg/kg, followed by 70 mg/kg every 4 hours times 17 doses. D. Adult 4 dose, 150 mg/kg infused over 60 minutes, followed by 50 mg/kg infused over 4 hours, followed by 100 mg/kg infused over 16 hours. D. Chronic APAP toxicity 1. Chronic excessive use or repeated overdoses of APAP can lead to chronic APAP poisoning. Often patients are treating pain with high doses of APAP from multiple or single source products. 2. Symptoms may be similar to those symptoms listed with acute ingestion or may be absent. 3. Labs A. If AST and ALT are normal and APAP level is less than 10 micrograms per milliliter, significant hepatotoxicity is unlikely. B. If AST and ALT are normal and APAP level is greater than 10 micrograms per milliliter, significant hepatotoxicity is possible. C. If initial AST and ALT are initially high regardless of APAP levels, significant hepatotoxicity is assumed. 4. Sometimes N-acetylcysteine is used, but its role is unclear in the treatment of chronic APAP toxicity. 3. Hepatitis, inflammation of the liver. A. Hepatitis A1. General information A. The primary means of hepatitis A virus, HAV, transmission in the United States is via the fecal, oral route. B. Hepatitis A does not become chronic. C. Most persons with acute disease recover with no lasting liver damage. D. Incubation period is 15 to 50 days, average, 28 days. 2. Persons at risk A. Travelers to regions with high or intermediate hepatitis AB. Sex contacts of infected persons C. Household members or caregivers of infected persons D. Men who have sex with men E. Users of certain illegal drugs F. Persons with clotting factor disorders 3. Prevention A. Vaccination with the full, 2-dose series of hepatitis A vaccine, Havrix, Vacta, given 6 months apart B. Immune globulin administered intramuscularly is available for short-term protection, 3 months, against hepatitis A both pre-exposure and post-exposure C. Good hygiene, for example, hand washing. 4. Signs and symptoms A. Some patients are asymptomatic, particularly young children. B. Symptoms occur abruptly and can include fever, fatigue, jaundice, nausea, vomiting, abdominal pain, loss of appetite, and dark urine. C. Symptoms usually last less than 2 months. 5. Serologic tests A. Acute, I'm anti-Hep B. Chronic, not applicable. 994 Chapter 49 3. A. 6. Treatment A. Post-exposure prophylaxis. 1. Healthy persons 12 months to 40 years. Hepatitis A vaccine. 2. People older than 40 years. IM immune globulin. 3. Children younger than 12 months, immunocompromised, people with chronic liver disease. IM immune globulin B. Confirmed infection. 1. No specific antivirals are available. 2. Supportive treatment is recommended. B. Hepatitis B1. General information A. Hepatitis B virus, HBV, is transmitted by contact with infectious blood, semen, and other body fluids. B. Among unimmunized persons, chronic infection occurs in 6% to 10% of adults. In chronically infected persons, 15% to 25% of people will develop chronic liver disease including cirrhosis, liver failure, or liver cancer. C. Most persons with acute disease recover with no lasting liver damage. D. The incubation period is 45 to 160 days, average, 120 days. 2. Persons at risk A. Infants born to infected mothers B. Sex partners of infected persons C. Persons with multiple sex partners D. Injectable drug users E. Healthcare workers exposed to blood F. Hemodialysis patients 3. Prevention A. Vaccination with hepatitis B vaccine, Recombivac's HB, Engerix B, 1, infants and children, 3 to 4 doses given over a 6 to 18 month period depending on vaccine type and schedule, 2, adults, 3 doses given over a 6-month period B. Passive immunization is obtained with hepatitis B immune globulin, HBIG, which provides temporary protection for about 3 to 6 months. 4. Signs and symptoms A. Fever, fatigue B. Nausea, vomiting C. Abdominal pain D. Jaundice E. Joint pain 5. Serologic tests A. HBsAg in acute and chronic infection B. I'm anti-HBC is positive in acute infection only 6. Treatment A. Acute, 1. No medication is available, 2. Provide supportive care B. Chronic, 1. Goal of treatment is amelioration of hepatic dysfunction and seroconversion of HBsAg positive, surface antigen, to HBsAg negative and production of HBs antibodies. 2. Treatment is indicated for chronic HBV infection with high pretreatment ALT level, detectable serum HBV DNA, and moderately active necroinflammation with or without fibrosis on liver biopsy. 3. First-line drugs, A. Pegylated interferon alpha-2A, Pegasus, I. Class, interferon, 2, dose, 180 micrograms square weekly, 3, duration, 48 weeks. Hepatic disorders 995. B. Entecavir,